Okay, good afternoon. Dr. Shubhas joined us. Nazdeen and Shelly is still pending. They'll come in their own sweet time. Nazdeen is usually late. And we are going to start off with Cystatin C. For some of you, maybe it is new, but it's not a new topic anymore. It was a few years back. And so Dr. Chogre said that she's done some papers on it. We'll give her a chance later to talk about it. So let's start with our first slide. As is, we say the history was first described as a gamma trace in 1961 as a trace protein together with other ones such as beta trace in the cerebrospinal fluid and the urine of patients with renal failure. So it is related to the kidney. Keep that in mind. Ruzbeh and Lobert first reported its amino acid sequence. They noticed that it had increased in patients with advanced renal failure. It was first proposed as a measure of glomerular filtration rate by Grubb and co-workers in 1985. That's when it came through. So what is cystatin C? It's a relatively small protein that is produced throughout the body by nucleated cells. It is produced and destroyed at a constant rate and is found in a variety of body fluids such as blood, spinal fluid, and breast milk. Cystatin C is filtered out of the body by the glomeruli, clusters of tiny blood vessels in the kidney that allow water, dissolved substances, and other waste products to pass through the walls, retaining blood cells and larger proteins. This is very much like what happens in the kidney. Kidney gets rid of what the body does not need and retains a small amount. Therefore, your kidney contains a little bit of urea, uric acid, creatinine. These are your solids. Evidently, the cystatin C is excreted. But when you find that, then there's a chance that the kidney is involved. What passes through the walls of the glomeruli forms a filtrate fluid. From this fluid, the kidneys reabsorb cystatin C, just like it does glucose when it is filtered and reabsorbed. I'm just giving you a small example. And other substances. The remaining fluid and wastes are carried to the bladder and excreted as urine. Something very similar to what happens in the kidney. And the small example I gave you was glucose. The reabsorbed cystatin C is then broken down and is not returned to the bloodstream. Now what happens to it? The rate at which the fluid is filtered is called the glomerular filtration rate, GFR. Decrease in kidney function leads to decrease in GFR and increase in cystatin C and waste products in the blood. Because cystatin C levels fluctuate with changes in GFR, that has been seen. Interest in cystatin C as one method of evaluating kidney function. Somebody in?
Yeah.
That's right. Who is it? Just a second, guys. Who is it? Go on. Nazin's here. Okay. That's right. She's in? Nazneen, we've just started. नाज़रीन तेरा हाथ जरा नीचे कर जे हाँ पछी नाज़रीन तेरा मोना पछी जरा हाथ पछी नीचे कर जे समझी के especially when Dr. Shubha is talking about it a little later there बराबर कर जे okay. So I said the rate at which fluid is filtered is called the GFR. Decrease in kidney function leads to decrease in GFR and to increase cystatin C and waste products in blood. Because cystatin C levels fluctuate with changes in GFR, there has been interest in cystatin C as one method of evaluating kidney function. So here you've got your kidneys, and your kidneys are situated in the retroperitoneal cavity behind in your back, two sides of your column. So how and where does it score iron in kidney function? Score over kidney function. Guys, there's a typo here. Unlike cystatin C, is not significantly affected by muscle mass, gender, race, and so on. When the kidneys are functioning normally, concentrations of cystatin C in the blood are stable, but as kidney function deteriorates, the concentration begins to rise. This increase occurs as the GFR falls and is often detectable before there is a measurable decrease in the GFR. While there are growing data and literature supporting the use of cystatin C, there is still a degree of uncertainty about when and how it should be used. Evidently. So what? Huh?
Someone is there.
Okay. Who is it? Just a moment, guys. Somebody else coming in. Who is it? Julie? Just a moment, guys. Somebody is. I have a. No? All right. Is that some? All right. So this is the slide we are at. What is the significance? An increased serum cystatin C corresponds to decreased GFR and hence to kidney dysfunction. Since cystatin C is produced throughout the body at a constant rate and removed and broken down by the kidneys, it should remain in a steady level in blood if the kidneys are working efficiently and the GFR is normal. Concentrations of cystatin C are not affected by gender, race, or age, and cystatin C is not affected by most drugs, infections, diets, or inflammation. So it's quite a stable compound as such. Recent studies suggest that increased level of cystatin C may also indicate an increased risk of heart disease, heart failure, stroke, and mortality. So one affects the other, so we have to be very careful. There's a picture here. So you've got disintegrating macroglobules. Macroglobule subunits fall apart. Little diagrammatical description. Tangled changes of tau proteins. So it is a protein product, a tau protein. Okay. Where else can it increase? That's the question we ask again. Cystatin C has been associated with hyperhomocystinuria, which is often found in renal transplant patients, and it has been shown to increase with progression of liver failure, liver disease. At least one study has looked at comparing cystatin C levels in serum with that found in pleural effusion to help determine the cause of effusion. These associations may or may not provide clinical useful data. So you can see that quite a bit is involved. You've got the liver, you have the pleural effusion, that is the lung, but the data is not correlating well here at this stage. Maybe some more data has come into now. Corticosteroids can increase levels of cystatin C levels, while cyclosporin can decrease them. In the absence of kidney disease, cystatin C levels may be elevated in rheumatic diseases and malignant diseases, although they are not affected by tumor burden, the amount of cancer that someone has. So again, you can see that it has a wide implication, but nothing proves substantially. Okay, so you'll get it somewhere in the cancer also. So we said, what about cystatin C? Mayo Clinic has some answers. Low molecular weight basic protein, 13 kilodaltons, freely filtered and metabolized in the kidney. Production is less influenced by age, gender, body size, cigarette smoking than creatinine. Therefore, blood levels reflect GFR better than creatinine. All right, I think that's the last slide. There's one more. All right, now this is important. Does it score over GFR tests? Yes, it does. It's only found in sera. That's one great advantage. Accurate estimation of glomerular filtration rate is essential for the diagnosis, staging, and management of CKD. A new immunoassay for determination of cystatin C has made it more practical and clinically useful to estimate GFR. A formula that uses both serum creatinine and cystatin C with age, sex, and race may be better than equations that use only one of these serum markers and may provide the best estimation of GFR and early kidney disease. And those of you who do GFR in the lab, you know that it requires a 24-hour urine specimen, it requires blood, it requires you taking the volume of the urine, and then you do the, if you're doing a GFR, you're doing on creatinine clearance, then creatinine in urine, creatinine in blood, and there's a certain formula that you follow. And luckily now your, what do you call, your computer, your, I'm not getting the right word, the algorithm is there, the calculation is there, you feed in this data and you will get the GFR. Otherwise, previously we used to measure the volume of the urine, tag it down, do the creatinine or whatever is asked. Usually creatinine clearance is asked, serum in urine, and using a certain formula of the patient's height, weight, age, you would work it out, and now you have an algorithm ready. You just feed the data into the computer and you get a reading. So here the formula is here. Urine concentration into urine flow upon plasma concentration. This is a very, very rough formula. And you can see the green levels where it is normal, and then you can see the abnormal levels where there is kidney failure. The rate, you can see that anything less than 15 is kidney failure. Between 20 and 55 is disease, and anything above 60 tells you the kidney is healthy. Again, now this is a Cobas system. It's a ready-made system, as you know, and is fed into the machine. Cobas Integra for Cystatin C is one machine that is used. This one. Cystatin C may also be useful for detecting those patients with CKD who are at highest risk of complications and progression. As an index of glomerular filtration rate, especially in patients with serum creatinine, may be misleading. Very obese or elderly or malnourished patients. Assessing renal function in the patients suspected of having kidney disease. Monitoring treatment responses in patients with kidney disease. So this is where it scores over the regular GFR, the long way. Okay. This is done. All right. Shubha, this is short and sweet. Would you like to talk about it right now? Because we've clubbed it together with CRP, C-reactive protein, which is very popular, as you know. Would you like to say something about what you have worked with on Cystatin C? I can't hear you. Unmute.
We have done it on reagent basis. We had the reagent from Accurex,
Okay.
and then got the reagent from Orthoclinical also. Here we did a comparative study from ICU patients, diabetic patients, where we saw that when actually this is a better marker, because ICU patients and old people, it is very difficult to get the 24 hours creatinine urine collection. So we have to do, and I have compared both the cystatin C value where we had the reagent based, and I have compared it with the urine creatinine clearance value also. So this is actually is giving a better result. But with service, you can also do a creatinine clearance also. There is no problem because most of the values were correlating. Okay, this is cystatin C value, which is a single serum based test. We have to take just the 5 ml sample, separate the serum, and on the serum we are doing it using the reagent. So this is a beta marker because then we have to do not have to do the collection of 24 hours urine. It is very difficult, especially when a child sample has to be collected, and then the height and the body surface area for a child is very difficult to estimate. Then even so it is indeed a better marker. Of course, it is expensive when it works on reagent basis. Formula wise, yes, it works out better, but we did everything on reagent basis, and we saw that it is a very nice marker to estimate diabetic nephropathy and the renal failure in diabetic patients. I will tell you one thing, my cousin is having kidney problem, means he is not into any failure, but because of his diabetes, he had started getting proteins in urine. He started passing lot of proteins in urine. Proteins means it was up to, say for example, 2 plus, 3 plus in urine. So then his doctor asked him to do a renal function test, and then he got a creatinine of 1.6, 2, etc. So then in that case, when cystatin C was done, they did it actually first on calculation basis. So when EGFR was estimated, that is estimated glomerular filtration rate, the cystatin C or the EGFR was how much? It was coming out to be high. Means how much was the EGFR? Actually it worked out to be somewhere like 56 and all. It has to be, GFR has to be more than 80 in normal sample. It is to be somewhere around 80, 90 or even 110. But in his case, it was somewhere like 50, 55. So then in that case, the doctor started a tablet for him, which is CRP, CREAP, CRP. That is a little expensive tablet, but with that CRP, his GFR increased. His creatinine came down. Means the cystatin C value, which was raised, came down, and the glomerular filtration rate increased. Now his glomerular filtration rate is somewhere like 74, 75. Means it was 50, 55. The GFR went up, the glomerular filtration rate increased, the cystatin C came down. So it is a very good marker for, I think, when a diabetic patient or a hypertensive patient or a patient with heart disease goes to a doctor, instead of measuring creatinine, cystatin C would be a better marker to find out the glomerular filtration rate. Like age-wise, it should be at least somewhere between 75 to 80. A low cystatin C, a high cystatin C and a low GFR is the marker to estimate chronic renal failure. So working on the value for cystatin C is a better marker. It is very good so far as children, pediatrics population is concerned. It is very good so far as geriatric people are considered, because most of the time they pass urine in the diapers and all. So it is very difficult for them to do a collection of 24 hours. this is only one prick and you get the sample and you estimate their GFR. It is very difficult for children also because they also pass urine in diapers. Then mentally challenged people also, it is very difficult, and most of the time these mentally challenged people are on these antidepressants which can raise their creatinine and which can harm their kidney function. So instead of doing a 24 hours collection, it is always good to do a one trick method, a 5 ml collection of whole blood and separating the serum and doing the cystatin C is much more better marker. So I appreciate whatever you have said is absolutely right. The definition, the details about the cystatin C, it's very, very good. It was a very wonderful presentation, and thanks for giving me an opportunity to opine on this. Thank you.
Thank you, Shubha. Nazreen, anything from your side? You guys into it? I'll open it to Rohaina also. Unmute.
Nothing from my end. I'm not actually working in the lab, so yeah. I will definitely look for this labs when I go to it. I visit labs, so I will definitely look it over and I will let you know.
Okay. Nazreen?
And I think it is a better biomarker because it is not dependent on the muscle. Actually, the difference between that GFR and cystatin is because for creatinine we are dependent on muscle mass. It is a product of muscle mass, creatinine, and cystatin C is liberated by all the nucleated cells. So it is a 50% higher, better biomarker used in labs now to detect early kidney degeneration. Also, it is not dependent on source. It is not the variables. It is not dependent on variables like age, gender, muscle mass. It is completely independent since it is what do you say, released by all the
Cells of the body, yeah, okay.
Yeah. And the accuracy of the test is highly sensitive when it comes to platforms like nephrometry. We were using Atalica nephrometer. Roche Cobas C501 is also giving, and Beckman Coulter's is also giving this platform. That's why nowadays more than, yes, EGFR is calculated, cystatin C is a direct biomarker, so the time also is less. That's why it is used more widely nowadays. But still, we still go with EGFR also. Most of the doctors do recommend EGFR also.
Yeah, but EGFR, I have noticed the technologist has to be trained in it. I look into 2 labs, one at Ballapur, one at Neral, and we had one where it was just absurd. The reading was just absurd, and then I had to take them through the whole procedure, and we had to redo it. So training the tech how to collect, how to measure, how to do the calculation is equally important. So don't you think so? Because I ran into trouble with these techs at the Badlapur and Neral. We had to train them as to how to go about it. Cystatin C is right, 1 drop, a little bit of blood, and there you are. Okay, can we
It is
say?
affected by antibiotics also. Antibiotics.
Yeah, we said cyclosporin and all. It does affect. It does affect. All right.
But
So
only cystatin C is not affected.
true. All right. So can I start with CRP, guys? C-reactive protein. I think all of you are very, very familiar with it. So let's go through it. And I was just talking to some of you, and you said that it has become so much routine, especially after COVID. It has caught on beautifully. Same way as when you're comparing it to ESR, such a long drawn out procedure. A CRP, you get results within 5-10 minutes. Okay, so CRP was first described in 1930 by Tillett and Francis, named after its ability to precipitate and interact with phosphatidylcholine residues of the C polysaccharide derived by teichoic acid within the cellular wall of Streptococcus pneumoniae, as well as its ability to precipitate with calcium ions. C-reactive protein is predominantly synthesized in the liver, typically within the transcriptional phase of the response to pro-inflammatory cytokines. IL-6 appears to be the main regulator by promoting de novo synthesis of CRP. And you remember CRP and IL-6 etc. became very, very popular at the time of COVID. So these are immunological markers. Routinely done for leprosy, although CRP is classically considered an important regulator of innate immune system and a paramount mediator of acute phase response, underlying that acute phase response. It has also been associated with various chronic inflammatory processes such as certain rheumatological conditions, cancer and CVD. Note now scores over routine tests like the ESR, and this is evidently obvious. You know that ESR requires citrated blood, proper dilution, loading your tubes, your PCV tubes, or your Vestagrant tubes or Winthrop tubes, depending on what you're using. You have to wait for an hour. If you're using Winthrop tubes, you have to spin it down to get your PCV, and then you have to have a special graph to calculate your corrected ESR and uncorrected ESR, and it's very, very cumbersome. As against CRP is a one-step process, just like we spoke in terms of Cystatin C and the GFR rates. So higher levels of C-reactive protein may be predictive marker in determining which patient with mild coronavirus disease, that's in 219, COVID-19, will progress to severe cases according to the study results. And you know, we did this on every patient suspected of COVID. Further, in this case series, researchers used data from patients admitted to a public health center in Changsha, China, from January 17, 2020 to February 20, 2020. All patients were diagnosed with laboratory confirmed COVID-19 and were deemed as non-severe case on admission. Knowing that a subset of mild cases will develop to severe COVID-19, researchers described the clinical characteristic of patients, analyzed related factors, and explored any predictable marker of disease aggravation. And the reference is Wang, Jiwu, and so on. You can see the reference below. A lot of work has been done in China on it. Why CRP increases in COVID-19? We asked that question. The levels increase of CRP might be linked to the overproduction of inflammatory cytokines. Cytokines fight against pathogen, but when the system hyperactivates, it can damage the lung tissue, and that is exactly what happened in quite a few of COVID patients who never survived or who have survived have the problem. CRP production is induced by cytokines and by tissue destruction. Additionally, secondary, also bacterial infections have been reported in severe cases. Clinical application can be used as inflammatory marker in fevers and infections, and you know today it's very common. Every day we get tests for CRP. Can also help to differentiate between viral and bacterial infections. Can also be used to monitor if the antibiotic given is effective, if the value comes down. CRP reacts faster than the ESR, obviously, especially very helpful in babies and young children, where you cannot collect large quantities of blood, which your ESR requires. Distinction of acute and chronic events reflecting the disease activity. Can also be used as a risk marker of heart problems, that is high sensitivity CRP, arteriosclerosis, insulin resistance, and other metabolic syndromes. So there is a slight difference between CRP and HSCRP. And HSCRP is used for cardiac function, so to eliminate it. Okay. Principles of determination. The present method determines CRP concentration by nephelometric immunoassays. I think we all are using that. When anti-human CRP serum antibody is added to CRP antigen in serum or plasma, an immunological reaction product is generated. The turbidity of the product is directly proportional to CRP concentration in serum or plasma. This turbidity is determined by wavelength 340 nanometers or by two wavelength difference measured method using wavelength 340 and a sub-wavelength of 700 nanometers. That's your red one. To obtain the CRP concentrations, on one end you got the violet and the other end you got the red wavelength. Alright. Let's go to HSCRP below, just click on it. Just a moment. So definition, high sensitivity CRP protein, that's what we call it. Similar to CRP, it is also an acute phase reactant, more sensitive than CRP, especially for cardiovascular injury. Normal test range less than 0.3 micrograms per deciliter. Okay. So now you have machines. I think this is a Ruzbeh machine. So high sensitivity CRP test, which is more sensitive than the standard test, also can be used to evaluate the risk of developing coronary artery disease, a condition in which arteries of your heart are narrowed, and that's what happens to most cardiac patients and episodes. Coronary artery disease can lead to a heart attack, and we've got machines that measure it. Can you click on it? Expand it a little bit. Micros, yes. This is a Ruzbeh product, and it sells pretty well. Okay. This is what we wanted to tell you, and I think that's the last slide. Thank you. Any questions? Interesting?
Very interesting.
Anybody else would like to add on what they know about CRP? Parul, you and Meena were talking about it.
Yes, ma'am.
Yes, ma'am.
Yes. Ma'am, my mother had a streptococcal infection in the throat. So the CRP was 50 when that report came. PSR was 74. So she was treated for it with the antibiotic. Clindamycin was given 10 days. She's recovered now.
Mm-hmm. It came down. You repeated the test again, or you did not?
No. Now she is well. Like
Okay.
the cough,
Oh, this was a recent episode, is it?
Recent,
Yeah.
just
Yeah.
the 3 weeks ago. She's completed the course.
Parul, anything from your side? In the family, somebody?
No, but during COVID,
Mm-hmm.
everyone was just only talking of CRP, that it's high and for people who had it. And then it became like for every disease, there's CRP. Even one of my friends who had cancer,
Mm-hmm.
she had a high CRP.
Mm, true.
So that's how they keep a track of it.
Correct. Correct. Ruhaina, anybody? Ah, good. Sorry. Bolo, Meena, tell me. Sorry.
Sorry, ma'am. Ma'am, there was one more instance, like one of her relatives, they were given some painkiller. So during the COVID it was, and because of the back pain, so the CRP was high. So the doctor said to do the RT-PCR, but that was negative. That time they were suspecting that it would be COVID, the CRP was quite high. Then they came to a conclusion that it was because of that painkiller, like the CRP was high, like they were diabetic patient, elderly patient. So that's what the doctor said. So that you shouldn't give such strong painkillers to them. That has pushed it up. So that is one instance. Yeah.
Anybody else? Ruhaina, anybody?
HSCRP is high in a young boy. Can I talk?
Yes, yes, please.
HSCRPI is in a young man. He says he's 35 years old. His father has a history of bypass done 5 years ago, 2 years ago, and now he went into cardiac failure. Means he has diastolic dysfunction, he has systolic dysfunction. His systolic pumping rate is only 35% or 30%, and now he is in failure. He is on failure treatment, cardiac failure, and this man got his work done on pathology reports, and his HSCRP is found to be 6. So he has a strong risk of developing the cardiac problem. So HSCRP means once it goes above 3, it is a very risky thing. I remember Chinese people coming to me once at Rishkandi Hospital, and they said that actually ESR, all the ESR tests for all the patients should be replaced by the CRP, where range is up to 10. Less than 10 is the normal range for our C-reactive protein. But in case of high sensitive C-reactive protein, it is up to less than 1 is normal. 1 to 3 is risk, and more than 3 is high risk. So it should be the HSCRP value should be kept very much up to 0.5 or 0.4. As you rightly said, the normal range is up to 0.3. So I have seen, when working at Rishkandi, I have seen that people who have this LPA, raised LPA, lipoprotein A, and those who have undergone bypass, their family people also, means their children or their siblings, had a high HSCRP more than, because for CRP we are using a different kit, and for HSCRP there are dedicated kits for measuring HSCRP. So these people had a value of around 2 or 3, 3.4, and this guy who comes to my place, he's a watch repairer, and he has got, right now, his father had 1 month ago during the Ramzan, he had a fulminant cardiac failure, and then there was a diastolic as well as systolic dysfunction, whereas there was a pulmonary hypertension, and he was immediately admitted because of severe breathlessness. So when this man got his workup done, he has HSCRP of value of around 4 or 5. So it is quite risky. So HSCRP is a very good marker, and it is a fact that what those Chinese people said, that I think there was a guy named Mandal coming to us, and he had brought these Chinese people to my lab, and they said that actually all the ESRs should be replaced by CRP.
Yeah,
so, madam, you are doing a very great job. Like these technicians, you said that this forum is for technicians, and really they must be getting to learn all these new things. It is a very good forum that you have started doing this PowerPoint presentations. I really appreciate. Thank you so much.
Ma'am, I would like to add something. Actually, there's one friend, his son, he was taking some, he had some psychological problems, and they had to put him on drugs. And he had done some intense physical activity, like going to the gym, and it was very intense. And that is the time his CRP increased. He didn't have any other infection or any disease or anything. So his CRP had increased, So that's the time the doctors thought he had some illness, but it was because of the drugs and the intense activity which he did. So that's when it happened. His CRP increased.
So that's the reason why you have to advise your patient. There are so many tests that we have that do not come to us after physical exercise. Calm down, cool down, come to us
Yeah.
2 hours later. And I think guys, you know that Dr. Shubha was chief of biochemistry at Breach Candy. That's the reason why she has a lot of data and a lot of knowledge about these cases. So when she asked me, I think I think one of our girls, Meena, Rajeshree's last day was 30th. Rajeshree's last day at Bhatia was 30th. She retired. And that, I think that's the time Shubha rang me up. I said, come on, come and take part. I'm sure she has a lot of things to tell us.
Yes, ma'am. We are very lucky, ma'am, that Shiva ma'am is there. Yes, ma'am. Lot of information. Thank you so much, ma'am. Really, really, very.
Thank you so much, ma'am.
I've seen a guy with severe exercises, and he just collapsed and died. And his lactate was very high. Lactate,
Muscle damage. Muscle damage.
So that is
Rohana, you saying something? Unmute. Rohana, unmute. Rohana.
No, I was I'm here.
Yeah, but unmute. I said I thought you were saying something. Nahi?
No, I wasn't. No.
Nazreen, what about you?
I'm just enjoying listening to all.
Okay. Nazreen, what about you?
And basically, what I have known from my work is because CRP is used as a non-specific marker. Okay, because it can detect inflammation in a very low time. The reason is because the half-life of the CRP protein is very less. So whenever there is an inflammation, a little bit of inflammation also it will elevate it. So that's why it is used as a marker, but it is a non-specific marker. We don't know the actual cause. So that's why we go for biomarkers and all these things. So basically, the reason why high sensitivity CRP came up, and then the CRP came up, and then high sensitivity came up because researchers were combining it with inflammations and reactions. So then they came to know that CRP, the way it rises also, it comes down also. So that's why CRP is used everywhere as a marker of inflammation. Whenever something goes wrong in your body, firstly, doctor will always advise for CRP because of that. Because the half-life of that protein, when
That's a good point. That's a good point. I agree with you.
That is very reactive. So it will speed up. It will give you the rate of inflammation will be detected sooner than any other protein in the body.
See, that's the reason why in COVID it became so important, Nazreen.
Yeah, that's the reason why in COVID it was used very extensively. When the patient comes to COVID also, they were doing CRP.
No, it was routine. It was routine. Besides
Sometimes
what you got from the
negative,
CBC.
CRP very high. But
See?
it cannot be that CRP is negative and COVID is positive. It cannot be like that.
But like I said, you had to correlate it with what you got in your CBC
Yes.
pattern.
Yes.
Your WBC, your inverse ratio, your lymphocytes. It became very important.
Reading the histograms is very important for technologists. Nowadays, technologists reading that histogram, the core training that we got, how to read first chapter in Todd and Stanford. I remember we were using Todd and Stanford, and Madam started. First thing we came to know how to read the histogram. That's very important.
No, you were first taught how to the electronic counting of cells was done. That was your first chapter.
Yes.
The electronic
remember
counting
that.
of cells. That is a cool term. Because that's what I told
the
you,
cool
that
term.
I was a student in America in 1970. Our people put us through the manual, red cell, white cell, blah blah blah, which the present techs don't know. I have to sit on my tech's head and repeat, Munira and I teach them exactly how to do a manual red cell count and white cell count. Can you beat it? Because they love the machine. So I told them when I was a student, the only thing we had was a coulter. It was like a little box which only did the red cell counts and the white cell counts, and you had to dilute it, pre-dilute it with a diluter. That's what we had, the original coulter. And I think by the end of that year, we got the SMA4, which did 4 parameters. This was a huge, big machine, that occupied 1/4 of our lab, And then we got the Humalog. A year later, we got the Humalog D, which was completely automated, So it was. This is how we progressed in hematology at Duke and at Watts Hospital. And I was very lucky. I had somebody. I think I was telling Munira, right, about Marion, somebody who looked after us, especially me. And she would make me sit because she worked the 12 o'clock to 11 o'clock shift. So she had a lot of time, and our time as students, we got over at 5 o'clock. So she would say, no. I want you to sit on those diffs. Right? How many diffs did you guys do? All of you in the year? 100, 400 minimum? 100 logged. Right?
Yes. 100 was compulsory, 100 was compulsory.
And 400 minimum, right? You agree?
Yes.
And that's what Marian put into our heads. And she saw to it that our reading of the differential was great. So also what came of the Humalog. Like you said, Nazneen, the histogram. The histogram becomes important. And I tell you, techs today don't know how to read histograms. In fact, I'm hoping that I can get somebody who would do one, maybe if I can get roped Jaldeep into it. Besides he's going to talk in terms of skills. If I can get Jaldeep into this, he was very good at interpreting the histograms.
Okay, ma'am. Sorry, I got to go. I have a meeting, ma'am.
No, we are also closing. So you carry on. Thank you for all the inputs, and that was a good point. How to read histograms.
Thank you, Dr. Thank you, ma'am. Thank you, everybody, for your time. Thank you so much.
Anybody else? Anything to say? And we'll say goodbye. It is 5 o'clock, right?
One point I want to tell about that, again going back to our first presentation, calcitonin. I would like to tell Parul that day I just went through, and actually calcitonin treatment is used for easing bone lesions, because the patients are in severe pain for bone lesions.
Yes.
And calcitonin is used in multiple forms, in drug form, etc. to ease
the pain.
To ease the pain. Okay.
Yes.
You said nasal sprays were given, right?
Nasal spray, but nowadays the drugs are also there to decrease the bone lesions, to ease the pain, etc. etc. Sorry, I'm interfering the first presentation with the last, but that is what I did come across something. So
Yes, ma'am. Thank you so much.
it is to relieve the pain actually. Okay.
Because even though it has so much given out in the body, still it's not enough, and that's the reason they give more of it during such a, like the multiple myeloma or something.
Yes.
Yes. Thank you, ma'am.
Okay.
Thank you.
And our next presentation is drugs, therapeutic drug monitoring.
Therapeutic drugs of monitoring.
That is a bit of a. I wish Esther would come on. Maybe in number 6 we'll get them on, because this is her subject. I'll see you guys. Thank you very much. God bless.
Thank you, ma'am. Thank you, ma'am. Thank you, Dr. Siddharth. Thank you.
Right.